Have you ever wondered why some health programs, the ones that show these incredible results in a controlled study, just sort of fizzle out when they hit the real world?
Oh, absolutely. It's a fundamental problem we see a lot in public health.
Right. Like, they seem perfect on paper.
Exactly. And the issue is traditional evaluations have often been way too narrow. They focus almost entirely on efficacy, basically. Does it work under perfect ideal conditions?
But not whether it actually makes a difference out there.
Precisely. It misses the bigger picture, the broader public health impact.
Okay, so that's exactly what we're diving into today then. We want to explore this framework called RE-AIM. It sounds like a really powerful model designed to bridge that exact gap, to help us understand the true reach, the real effectiveness of health interventions in, everyday settings.
Yeah, moving beyond just does it work to does it actually matter for real people in real situations?
And for this deep dive, we're mainly looking at a key paper by Glasgow, Vogt, and Boles that lays out this RAIM model.
That's the foundational piece. And we'll also connect it to some ideas from community-oriented care, because that really highlights the kind of programs that need this type of robust real-world evaluation.
Okay, so let's unpack the old way first.
Yeah.
This efficacy-based research paradigm. You mentioned it focuses on ideal conditions. What does that typically look like?
Well, you often see studies using very specific groups of people, think homogeneous, highly motivated individuals, and it all happens in these very controlled, almost artificial environments.
Which gives you strong results in that setting.
Exactly. You get strong internal validity. You're pretty sure the intervention caused the change there. But the big catch is it often tanks the external validity.
Meaning whether it works out in the wild.
Right. Will it actually work for you or in your community clinic, not just for those handpicked people in the lab? This leads to interventions that can be really intensive, expensive, demanding, studied in these sort of rarified, controlled atmospheres like specialized treatment centers. They just don't tell you much about how that program performs in, say, a busy, maybe understaffed public health clinic or a normal community setting.
And that's critical if you want population-level health improvements.
Absolutely crucial. The hard truth is, many interventions that look great, really efficacious in those randomized trials are, well, much less effective when you try to roll them out to the general population.
That's a pretty stark reality check.
Okay.
So if those super controlled studies often miss the mark for the real world, how do we measure what actually makes a difference? This is where RAIM comes in, right?
Exactly. And it's, I think, a really insightful model. It proposes 5 key dimensions we need to look at to understand the true public health impact.
5 dimensions. Okay.
And crucially, the overall impact isn't just adding these up. It's more like they multiply. If any one of these 5 dimensions is 0 or close to it,
The whole thing collapses.
the total public health impact can be drastically reduced, or even vanish entirely. It's like that bridge analogy you used earlier, miss one key support.
And the whole structure is compromised. Makes sense. Okay, let's break down these 5 dimensions. What's the first one?
First up is reach. So this isn't just how many people will get the program, but also how representative they are of the target population.
So are we actually reaching the people who need it most?
Yeah.
Or is it just, the worried well or maybe more affluent groups who have easier access?
That's a key question. Assessing representativeness can be a real challenge, but it's vital. Then comes efficacy.
Okay, this sounds like the traditional measure. Does it work?
Yes, but with a twist. It's a success rate if implemented as intended under ideal conditions. But RE-AIM pushes us to look beyond just, say, physiological results. We need to assess both positive and negative consequences.
Like side effects or maybe impacts on quality of life?
Exactly. Quality of life, behavior change, even participant satisfaction. Is the program effective overall, considering everything, not just did blood pressure go down?
Got it. What's next?
Adoption. This looks at the settings. What proportion, and again, how representative, are the settings, think work sites, clinics, schools, communities that actually take up the program or policy?
So it's not just individuals, but the places that deliver the intervention. Are they diverse or are only certain types of clinics adopting it?
Precisely. Then comes implementation. This is all about fidelity. To what extent is the program actually delivered as it was designed, but in the real world, by regular staff, not the original research team?
Because a great program delivered poorly isn't going to work well.
Right. Implementation interacts directly with efficacy to determine the actual effectiveness you see on the ground.
Okay, that's 4. What's the final one?
Maintenance. This is the long view. Sustainability. At the individual level, it's about long-term behavior change. We know relapse is, well, it's ubiquitous after initial changes.
So does the change stick?
Yes. And at the program or setting level, maintenance is about institutionalization. Does the program become part of the routine, part of the everyday culture of the clinic or the worksite? Or does it fade away once the initial funding or enthusiasm dries up?
Okay. Reach, efficacy, adoption, implementation, maintenance, REAIM. So putting it all together, what does this framework really do for us?
Well, it gives us a much more robust way to figure out which programs are truly worth sustained investment, which ones actually work, not just in theory, but in complex, messy, real-world environments.
It helps sort out what really makes a difference for whole populations.
Yeah, and it brings up a fascinating point. Sometimes programs that are super, super efficacious, maybe because they're intensive or costly, might actually score poorly on reach or implementation in the real world.
Because they're too hard to roll out widely or too expensive.
Exactly. So paradoxically, sometimes maybe a lower intensity intervention, one that's perhaps less efficacious individually, but that can be delivered easily to huge numbers of people.
That one might actually have a bigger overall public health impact.
It could well do. REM helps us see that trade-off clearly. It broadens our whole idea of evidence beyond just that narrow efficacy piece.
Giving decision makers much more complete information to work with, it sounds like a fundamental shift.
It really is. It moves us past that simple, almost limiting question of, does it work?
And forces us to ask those crucial follow-ups.
Does it work? For whom does it work? Under what conditions? In what settings? And for how long?
That paints a much richer picture. So, a final thought for our listeners. Next time you hear about a new health initiative, maybe a new program being launched, how will you assess its true potential impact, thinking beyond just whether it can work?